we've got 10 minutes, and what I'm going to spend 10 minutes to do is trying to convince you that actually any of the lines that we draw in the sand are completely arbitrary. And actually, all we're looking to do is what's the best value for Mike's £250,000 per annum. And actually, we can probably improve upon that by using some modelling. Because this is the current criteria which the expert panel that Mike mentioned is going to come up with. Essentially, it's very similar to your standard IVF criteria. You've got to be aware before your 38th birthday. You've got to be slim or obese. Obviously, 1 in 5 of us are now obese in Scotland, as the same in England and so on. Our children, 1 in 5 of them are obese. But essentially, so BMI is a measure of how fat you are, and obese is beyond 30. But we're prepared to treat people all the way up to 35. But I'll come back to that and I say, is there any rationale for that? You have something called anti-Müllerian hormone above 5 picomoles per litre, and to ignore that for just now, we'll come back to it. You need to be in a stable cohabiting relationship. What I mean by that is you need to actually live together for about 1.5 years. We just do it on a time basis, and you might question actually that because you might have met the woman or man of your dreams within the first 6 weeks and moved in and got married. But actually, you wouldn't qualify for IVF until you've been there together for 1.5 years. You've got to have viral screen negative, so you can't have HIV, Hep B, or Hep C, and you can't have any unaffected child resident. So despite the fact that you know that you're going to have a genetic condition, if you've already got an unaffected child, you can't get NHS-funded PGD. So you might have one genetic abnormal child, so you know what all that entails for you as family. You've got one normal child, but you're not going to get a third one on the NHS through the PGD program. Sorry, Mark. So, what you've heard, and you know, it's beautifully illustrated there by Mary, was essentially what determines the success rates of IVF is the number of eggs that you've got. And essentially, this looks like a complex slide, and some of these will look at that. But the problem is that women are born with a certain number of eggs. They've got the most number of eggs they'll ever have in their life when they're 20 weeks as a fetus inside their mum's tummy. And then it's all downhill from there. And you lose them, and you go, eventually, you lose them like this kind of pathway, and by the end of 51, which is the average age of menopause in the UK, you've lost them all. Okay? So the problem that we've got is that we have people come into the clinic, so we can have a Jan who's got lots of eggs for her age, she's a 30-year-old, lots of eggs, or you've got a Sarah who's got absolutely rubbish number of eggs. And how do we begin to identify them in the clinic? Because as you've said, Mary's shown you, is you need lots of eggs to start with to be able to get the embryos. So how can we identify a Jan who will be well in the PGD program against a Sarah who just failed at the first step? And the answer to this is something called AMH. So this is new hormone, it's anti-Müllerian hormone, and this is a picture of an ovary. Which is say this is a whole ovary here, and what we've stained up here is AMH has come up in brown. We've done the kind of immunocytochemistry technique, and you can see these are the follicles, and these are the the follicles where the eggs are being kept that we're going to pick up in this IVF cycle. And the beauty of AMH is it's produced in the follicles that are currently going to be recruited in that IVF cycle. So when I stick a needle into that ovary, that's where the AMH is coming from. So it very closely relates to the number of eggs you get. So it's not being made by all these other follicles which aren't yet active and so on. It doesn't tell you about them, but it tells you the ones you're about to get the eggs from. And what we're pretty confident is we know what AMH should do. We've got data from 25,000 women. Some of you in the room might have been one of these, some of these women. But essentially, we know how AMH declines across the lifespan. So just like I showed you those eggs fall down, so does AMH. So AMH on an average on a 35-year-old will be 10 picomoles per litre. This is the 50th centile, so completely average. And by the time she's 40, it's down at 5. Okay. And the way that it relates to it is, you can see here, this is AMH getting higher up along this kind of x-axis here, and the number of eggs that you've got here collecting in an IVF cycle on the y-axis. And what you can see is this beautiful relationship. As your AMH gets higher, the number of eggs you get goes up. So when Mary is trying to think, okay, how many embryos do I need to have? Well, I can be pretty accurate and say, well, if I know her AMH, I will be able to say that we can get, if it's in this region of 10 picomoles per litre, we will get about 8 eggs. But if she's down here and it's less than 4, we're only going to give it 2 or 3 eggs. And that's insufficient, as you've seen, to be able to do the PGD on. So there's no point bringing these people into our program. So that's why we have AMH. Now, what about obesity? Well, the problem with obesity is that essentially it's associated with every single pregnancy complication you can think of. So no matter what you think, whether or not it be preeclampsia or gestational diabetes, or whether or not baby's got congenital abnormality like spina bifida or diaphragmatic hernia, all of these things are increasing. Miscarriage rates, chance of having a cesarean section, forceps delivery is all increased. Infection, depression, premature delivery, stillbirth, it was all in the press last week with the Lancet series. Babies get stuck, babies die, they're all increased. So you think, well, what on earth are all these 1 in 5 women doing getting pregnant while being obese? But the problem is essentially that all the risks increase just linearly. And what I mean by this is an example of preeclampsia, which you might have heard of, is where you get high blood pressure and get protein in urine. And the treatment for it is you deliver the woman. And essentially that cures it. It's a placenta-based disease of afterbirth, and so you get rid of the placenta by delivering them, they get better. But the problem is that you're delivering babies in 24 weeks, 25, 28 weeks, and all the associated costs for that. But you can see here is that essentially this is a summary of every single study that's been done on relating obesity to preeclampsia. And what it is this is the BMI across the bottom here, so people will be very slim, about 18, going up to 36 up here, and what's the chance of getting preeclampsia? And what you can see is if your BMI is about 30, you've got about an 8% chance of getting preeclampsia. And if I bring it up to 35, well, that's then 12% of getting preeclampsia. But that's the whole range. Some people will get preeclampsia at 39 weeks, and some will get it at 24 weeks, and it's 24 weeks ones that have huge implications for us. But the reality is that still means that even with a BMI of 35, 88% of those pregnancies will be completely normal and not be affected by preeclampsia. So actually, as I say to you, when we're going to draw a line in the sand about this, where do we say the risk is adequate? There's no clear threshold effect. It doesn't suddenly step off and start going through the roof. It's just a gradual increase across that. So any cut-off in terms of how fat people are is going to be relatively arbitrary. And the question is, well, do fat people get pregnant? Well, we all kind of know that, don't we? So they do, and there's lots of them around. And this is just, do they get fat people get pregnant when they have IVF? Well, yes, they do as well. And this is a bit of data to show you how it is. And this is the biggest data in the world and so on in terms of this. But it's just to give you some analysis. I realise it's a complex slide. I'll talk you through it. So essentially, some people at the top left here getting a wee bit fatter, this is normal, and then a wee bit overweight, and then obese, right? So essentially, you need to give them a wee bit more drugs. We have to give them a few more days of drugs, but that's okay. They'll have a higher chance of cancellation because they don't respond to drugs, but only about 5%, so 1 in 20, well, I'll take my chances with that. I'm fat, but 1 in 20 chance that I'll still get the Negligible. That's okay, thanks very much. Or you can say, and they might get split a few eggs, but hey, they've still got 7. And given that when Mary was working with 5, that sounds pretty good. I'll take my chances. And similarly, they might have a slightly higher risk of miscarriage, 7.8% against the 5 if they were slim. But that's okay, 1 in 20. And they still get pregnant. And if you 16.9 against 21% down here, so a slightly lower chance of having that live birth. But you do multiple goes, and you get 50% of them pregnant against 41%, so you end up with 2 of 5. So here is, again, diagnostic criteria. You can extend this up to 35, 40. It's a similar trend. So essentially, we're putting arbitrary lines in the sand, but it's not impossible for these people to get pregnant. So what about smoking? Essentially, we're all in here, and I noticed that no one kind of nipped out for a fag, but if it was Glasgow, they certainly would be happy to get there. So essentially, this is a study of all the smokers. So if you live in Edinburgh, you don't get IVF if you smoke. But you come to Glasgow, you do. So anyway, essentially this is a summary of all the studies that are looking at smoking and what's the chance of getting pregnant. So if it's to the left here, you've got less chance of getting pregnant, and if it's to the right, you've got more chance, okay? And essentially what they all show is that there's about half the chance, if you smoke cigarettes and you get IVF, it's about half the chance of succeeding. So you need twice as many cycles to get pregnant if you're a smoker. So it all sounds awful, doesn't it? You're fat, you smoke, and is there any chance of getting pregnant at all? Well, actually, you can, and we can predict people who will get pregnant. And this is where it comes to what's the best value for money for your £250,000 per year. So we've come into this analysis of 144,000 cycles. So every patient who got IVF in the UK between 2004 and 2008, and we published this in a medical journal called PLOS Medicine, which is open access, you all get to read. But we also created this website called IVF Predict. And essentially, it went all around the world, CNN, ABC News, BBC, and my grandmother really being proud because it was even in the Sunday Post. But essentially what it enables you to do was you put in these 9 questions. So how old you are, how long are you trying for, whether or not you're using your own eggs or donors, what's the cause of your infertility, whether or not you're on the first go IVF, or your second, third, fourth, have you been unsuccessful IVF before, have you been pregnant before, was that related to IVF or not, did you have a miscarriage, what type of drugs are we going to use, but we'll tell you the default for that, and we'll use this ICSI technique. And from all of that, you put that in, it takes less than a minute, and it gives you your chance of success from IVF of 22.8% for this woman. So the reality is that when you look at these mathematical models and we think about how that works, it really is trying to take people into low risk groups, medium high risk, and high risk groups. And if we think about that, that's exactly what we do for blood pressure screening and whether or not you should be on a statin. So some of your mums or dads or yourselves might be on statins, and it's because they've gone along to a GP, had their lipids measured, their blood pressure, and their age, and say, yeah, you're high risk for having a heart attack in the next 10 years, we're going to put you on a statin. It doesn't necessarily mean that you're definitely going to have one, but if we have 100 people in the room, 20 of you will be having a heart attack, and they feel you're high risk, and we're going to try and reduce that risk. So that's exactly what this is all about. So it's calibration of a model. So you can see here, this is a decile. So we take, this is 14,000 women in this bottom group here, another 14,000 in this group. And you can see that the live birth rate increases from 7% down here at the bottom group, all the way up to 35% at the top group. And that's what happened in real life. And in terms of the model, it predicts that perfectly, almost. So we can predict, using the IVF predictor stakes a minute, where these people are going to sit within the spectrum. And the advantage is that in terms of a commissioner, you say, well, actually, do we really want to be thinking about these people here, or do we want to just be treating this group here? Or if you're a commercial IVF organisation and you want to be top of the league tables, well, you select these people, don't you? And you charge them lots of money. So that's the key. And actually, it's all about setting your threshold for big bang for your buck. I've told you about EMH, and that's a critical thing to get in. But then it's all, how do we get the money? Because essentially, what we've got is this concept here. And this is for, at the bottom end, these people are going to have a low live birth rate. And so actually, we don't want to treat them ever. Now, it might get up to 17%, but actually, that's not great value for money. In contrast, times are good. Well, not anymore, it's, we're in recession, but perhaps these people are in an amber zone where if money was plentiful, they could also get treatment. But at the top end, where we've got limited funds, these are the people that we should be treating. And in reality, that would mean that you'd always be getting success rates above 30%. Because this was done in an infertile population, we can potentially apply this to the PGD population as well, and select out the best people. But it won't be the same criteria that I showed you at the beginning that we're using, by any manner of means. And so when you think about it, it's all about money, isn't it? It's all about where do we get our best value for money. But in reality, is that what you do for cancer? Now, most ways we think of cancer is we throw absolutely everything at them. Do you see any sort of 70-year-old men who smoked all their life, and you say, well, no, actually, we're not going to give you your lung cancer treatment? Not at all. They get absolutely everything, the same as a 50-year-old do, or a 30-year-old would do. They get the same options. It's not based on the fact that quality of life. And I personally, I'm all for that, because this is me. My wife, she had breast cancer 3 years ago. My son, he was only 1 at the time, and this was the morning we shaved her hair. But the reason why we do that is because we're hoping to get a healthy outcome when you go to your brother-in-law's wedding. And the reality is, that's why we kind of do this. It's an emotive subject. But it's images like that one that I've used on the right that actually give people money to cancer, makes cancer a priority, when actually this guy here, Cal, my son, is really sort of selling my immortality. Because actually Cal will go on for future generations. And that's what we can do with IVF and PGD. It's immortality for future generations. So actually, just to summarise, I think access criteria to IVF are all arbitrary lines in the sand, and hopefully I've managed to convince you that in 10 minutes. It's financial pressures that are going to dictate that. But unlike cancer or cardiac risk, we're completely behind the times, and we've not done any economic modelling for that. And actually, if we had done, we'd be choosing a completely different set of criteria potentially. Because I think we can now predict IVF success rate. It's certainly feasible, and we can do that very accurately. AMH is a critical thing because it ensures we get adequate eggs to get into Mary's lab and Marco's labs to make sure we do that. And that's one thing that was always going to be here. And I think obesity increases the risk of pregnancy complications, but it does it linearly. So any line we choose, we have to accept as arbitrary. do we have it high and we give everyone a chance, or do we bring it right down because it will have an improved chance of having a healthy baby at the end of the term? And that's exactly what we've done with twins. You know, we moved them to single embryo transfer to avoid the chance of having preterm babies born from multiple pregnancies. And then lastly, smoking decreases the success rates, but if you do smoke, you need to come to Glasgow. Thank you very much.